Thank you for attending this webinar. What is the situation of synthetic slings for the treatment of female stress urinary incontinence? And tonight we are going to have Elisabetta Constantini from Perugia. We are going to have Frank van der Aa from Leuven, from Belgium, and myself, Francisco from Portugal. And we are going to discuss what is new in this area. This UROwebinar is organized by the European School of Urology online in collaboration with the European section of Female and Functional Urology. And the webinar is accredited. So you might receive one European CME credit if you complete a questionnaire and send it back to the office. So be aware of that if you want to receive the credit to answer the questionnaire. The flow of the webinar will be the following. I am going now to present the clinical case after this introduction. A very straightforward clinical case of a middle-aged woman with stress urinary incontinence. Elisabetta Constantini then will tell us which are the recommendations from the guidelines for the surgical treatment of female stress urinary incontinence. Then I will show data about single incision slings, which might change the recommendations of the guidelines. And the third talk will be given by Frank van der Aa, and he will speak about the issue of single incision slings, if this data can change the practice of functional urologists. And hopefully, in the end, we are going to have about 10 to 15 minutes to answer to some of your questions. You may put your questions, of course, writing them, and we can read them, and we'll try to answer during the presentation or eventually at the end during this period of questions and answers. So the case is simple. Is a 55 years old woman. She's a teacher. She has stress urinary incontinence for several years, but she is worse in the last year. She got worse. She is now using 2 to 3 pads per day. She's bothered because of that. She's a teacher. She has also coital incontinence, and she's not very happy because of that. But she has no OAB symptoms. She has no urgency, frequency, or nocturia. She received the pelvic floor muscle training in 2021, but without significant improvement. She had 2 pregnancies many years ago, 26 at the age of 26 and 30. She had her menopause at the age of 51, so 4 years ago. The body mass index 26.8. She has a very active lifestyle, sexually active, and she has no other pathologies, and she had no surgeries, pelvic surgeries before. In terms of physical examination, urethral hypermobility. She has no signs of vaginal atrophy or estrogen deficiency. She has a positive cough stress test. She has a positive Bonnet test, and she has no post-void residual. I did not perform cystoscopy. I did not perform a PET test, and did not perform urodynamics. She told me that she is quite concerned about the discussion about the amount of mesh that she might require to treat her stress urinary incontinence if she receives a synthetic sling. So, said that with this introduction, Elisabetta, would you like to tell us the recommendations from the guidelines, because you are now a member of the guidelines?
There was a problem, but I don't know why. Okay, well, first of all, I want to thank Francisco to organize this webinar. And I am one of the members of the female guidelines. And I like to, these are my conflict of interest. And I want to share with you some important points on which we worked a lot when we started to work on the female guideline. And first of all, this is a typical case, very common, and but only in the recent guidelines we had a clear consensus on the definition of a uncomplicated or complicated stress urinary incontinence. And we reached the consensus on this definition that you can see here. So we have a patient with uncomplicated stress urinary incontinence when no prior surgery was performed, without any kind of pelvic surgery or pelvic radiotherapy, and no lat dysfunction, neurogenic lat dysfunction, and no bothersome genital urinary prolapse, and the absence of voiding symptoms and storage symptoms, and no medical condition that affect the lower urinary tract. So this is a typical case in which we can perform surgery after pelviform muscular training, which the patient has performed before. And at this moment, we have to decide which kind of surgery. I want to show you really briefly which are the most important surgical procedures that are performed in case of an uncomplicated stress urinary incontinence. As you can see, I designed a circular timeline with the Bush colpus suspension as the first, and then moving to the pubovaginal sling, and then in 1995 with the transvaginal tape and the transobturator tape, and in 2006 with single incision slings with bulking agents, with the particular aspect because it was not performed generally at the beginning in an uncomplicated case, but I do want to deal about this. But we know that after 2011, with the break by FDA, there was really a lot of discussion on this and the use of, in particular, on medial slings. So the timeline became circular. So in this moment, again, in many countries, Bush colpus suspension and pubovaginal sling, which were abandoned, are again used for treat this patient. But I don't want to enter in this field. What I think that it's really important that we refer to a review published in 2010 in which we describe what is happened in the world. So we know that for many women, mesh surgery is trouble-free, and we have a lot of improvements in their condition. But this is not the case for all. And we don't know exactly which is the real number of women who have complication, and probably they are the minority. But on this, at the same time, we cannot not take into account the nature of the patient who suffered for this complication, and we have to be really careful when we use mesh in general. And another important point that we are included in the new guidelines, in 2023 guidelines, is that two important points has to be really taken in consideration. From first of all, surgeons and centers characteristics. So we have to be trained in the field of urinary incontinence and for each surgical procedure. And on the other side, all the decision on the preferred or the best procedure to be performed should be a shared decision-making approach. And I don't want to enter into the particular aspect of this decision, but it's included in all the new guidelines. And as you can see in the next 2023 guidelines, we will have this point as a new recommendation which is a strong recommendation to employ the shared decision-making approach when deciding on an appropriate treatment for stress urinary incontinence. Well, in the guidelines, we have all the principal procedures which are used to correct stress urinary incontinence. And these are the most important recommendations that you can find in 2002 and also in 2023 about the colpo's suspension. You can offer colpo's suspension to women seeking surgical treatment for stress urinary incontinence following a discussion of the risks and benefits relative to other surgical modalities. At the same time, you can offer again also an autologous sling placement with the always with the shared decision on the benefits and risk of this procedure. And regarding the urethral bulking, this is a different story because bulking edges were used for many years, not in uncomplicated case, but in complicated case. In any case, we know that this procedure is a low-risk procedure, and the structural recommendation is to use, but we have to speak with the patients and telling us that the efficacy is lower than the other surgical procedure, and that sometimes we need repeat injection, and that long-term durability and safety are not established. While when we move to the midi-urethral sling, as you can see, we have different strong recommendation. Again, we can offer after a thorough discussion of risk and benefits. And we know that another strong recommendation is that the long-term outcomes for TVT are superior to the transobturator route. And we have to inform women on complication. And I have this recommendation that is highlighted because it's a new recommendation that you will find in the new guidelines. And in this webinar, we will discuss why this recommendation was introduced. It's important, but we have to inform that single incision slings, in particular Adjust and Altis, have a strong recommendation, but the short-term efficacy appears equivalent compared to conventional midi-urethral sling. And there are some reasons that will be explained from Francisco and from Frank about the reason for this new recommendation. And we have some controversial point, in particular on the dyspareunia, which is a controversial point when we perform a single incision sling. And finally, just to be complete, we have other treatments available also for uncomplicated stress urinary incontinence, and but the recommendation in this area that we can offer both mechanical devices or an artificial urinary sphincter or an adjustable compression device, also in case only as a part of a well-conducted research trial. And we need to know that this kind of procedure can have some complication and should be performed also only in expert centers. And I finished my presentation, and we can open the discussion. We can go to Francisco for the data which changed the guidelines today.
Thank you, Elisabetta. So let's go to my presentation. So which are the new data about single incision slings? You mentioned, Elisabetta, that may change, or they are changing the guidelines actually already. Well, these are my disclosures. And when mini-slings were introduced in 2006, very quickly many of us start doing studies comparing standard midi-urethral slings with the mini-slings. For example, in this study, we were comparing TVTO with two types of mini-slings, one that is already out of the market, the Secure. The other is also out of the market, but simply because the name changed, but it is exactly the same. Now is sold as Solix. And at 1 year follow-up, in a small number of patients, in fact, we conclude that mini-arc was not inferior to TVTO, and the postoperative pain with mini-slings, with mini-arc, was less than after TVTO. After that, other studies came out, and this one with the adjustable mini-sling, the Adjust, still are also at 12 months as a follow-up, but with a larger number of patients, almost 150, as you can see in the two arms. The conclusion is similar. The pain after the operation was less with the mini-slings, and comparing from the objective point of view, the stress test, or the subjective cure rate using the ICIQ short form. So patients that that had an objective cure were similar in both sides, and those that said I never leak or I leak very occasionally, summing up the two, we conclude that exactly the same numbers. So the two types of slings provided equivalent outcomes. 12 months is short, it's too short, so the data started to enlarge, and in this study, 36 months is a follow-up, so 3 years, comparing mini-arc with monarch and looking into subjective cure rate using the patient global impression of improvement and the objective cure rate using the cough test. The conclusion is the same. The two types of slings provide exactly the same outcome now at 3 years of follow-up, and with a reasonable number of patients, although it was not very high, about 70 patients in the end. So clearly, it was necessary to carry out a multi-center large study, and that was carried out by Mohamed Abdel Fattah. It was published last year in New England Journal of Medicine, and involved almost 300 patients in the two arms: single incision mini-slings, two types, Adjust or Altis, and the standard midi-urethral slings. So these are the demographics, and I think it is relevant to analyze the demographics of the study. The age of the patient, around 50 years of age, which means that coincides with the maximum prevalence of stress urinary incontinence in women is around the middle age. The body mass index around 28, so normal patients that we tend to see every day. In terms of parity, around 2.4, so between 2 and 3 pregnancies, which is also the typical situation we see. And in terms of diagnosis, although the patients did urodynamics, and that is controversial for clinical practice, remember this is a randomized clinical trial, and it was important to know for sure that the patients had stress urinary incontinence in the majority. Very few had mixed incontinence with a predominance of stress urinary incontinence. And these are the outcomes. First, the time necessary for the surgery. around 40 minutes for both, slightly lower with the single incision mini-sling, but because it is adjustable, it might take a little bit more time than a non-adjustable mini-sling. The type of anesthesia, I call your attention to the fact that with single incision mini-slings, 72% of the patients could do the surgery under local, while the standard midi-urethral slings, 91% of the patients ask for a general anesthesia. That is relevant, of course, from the economical point of view. In terms of postoperative stay less than 1 year, the return to normal activity, well, slightly inferior for the single incision mini-sling. And in terms of pain after surgery, you can see that the pain after surgery was lower with single incision mini-slings compared to the standard midi-urethral slings. In terms of outcomes, in terms of the treatment of stress urinary incontinence, in terms of PGI, patient-reported outcomes, so at 15 months of follow-up, we don't see differences between the two, and at 36 months, we go on not seeing differences between the two types of slings. If there is some difference, apparently it seems to favor the single incision sling, but for a small percentage. In terms of objective cure rates with a 24-hour PET test, you can see again that the results are similar at 15 and at 36 months between the two types of slings. And if there is some difference, apparently it looks like that it might slightly favor single incision sling, but there is no statistical difference between the two. Adverse events. It is also relevant to talk about adverse events. And during the operation, the single incision slings had no risk of bladder or urethral injury. The standard midi-urethral slings have some risk, although very low. In terms of bleeding, large serious bleeding were very rare in both cases. And when we talk about bleeding, but not serious bleeding, there is less bleeding with single incision mini-slings, but it is not a relevant difference between the two. Dyspareunia is an issue, and that it has to be clarified because at 15 months of follow-up, 17% of the patients refer dyspareunia compared to 5% with the standard midi-urethral sling. And although that tend to fade away at 36 months, still there was a significant difference between single incision mini-slings and standard midi-urethral slings. Something that has to be reviewed because it was not observed in other studies. And in fact, if we go back to the EU guidelines in 2022, it was stated that the blood loss was less, that postoperative was less compared to conventional midi-urethral slings, and actually that the improvement in sexual function appeared higher with single incision mini-slings than with standard midi-urethral slings. So this is the first study showing exactly the opposite, and this has to be reevaluated, reanalyzing the data and eventually making further comparisons because something has to be clarified in this point. I must say that in our center we did some studies in addition to comparative studies with mini-arc, with Solix, comparing the efficacy of these mini-sling in patients according to age, and age was not relevant in terms of efficacy. Body mass index was not also relevant. The Valsalva leak point pressure, although not recommended by the guidelines, low Valsalva leak point pressures or high Valsalva leak point pressures the results were exactly the same in terms of cure or improvement of stress urinary incontinence. The only difference we saw was in the baseline number of pads patients were using. Parental patients that required more than 5 pads per day, so meaning that probably they had a more severe form of stress urinary incontinence. These patients had a worse outcome. Elisabetta mentioned the problem of the long-term data, and the long-term data are now appearing from Belgium. Manuela Tutolo compared mini-arc against monarch at 6 years of follow-up, and there is no difference. And Margarida Manso in our department, she investigated patients that received mini-arc at 10 years of follow-up, and we can see that from the patient global impression of improvement, about 2/3 were very much better or much better, and 70% of the patients consider the situation normal or causing very mild problems. So the situation looks like that we should conclude that single incision mini-slings are at least up to 36 months in randomized clinical trials. In cohorts up to 10 years, they are effective. The surgery might take less time to be performed and might be performed under local anesthesia. I think this is probably an interesting point to discuss because it is relevant from the economical point of view due to the high number of patients we have with incontinence. Less pain in the postoperative period might speed up the process of returning normal activities by the patients. And we have to check the improvement of sexual life and the incidence of dyspareunia, because there is some controversy here, and this needs to be clarified because we need to inform our patients in this topic very clearly, because they are young patients and most of them sexually active. So I am going now to interrupt my screen and hand over to Frank.
Okay, thank you very much. I think there might be a question. Ioannis Michailidis raised his hand. Do you have a question? If so, you can ask it.
The question was no long-term effectiveness known. It will be for elderly poor risk candidates. We have already some data, but from cohorts in terms of long-term. Clearly, we don't have randomized clinical trials beyond 36 months, and we are not completely sure if it is more effective in elderly patients than mini-urethral slings. That is something that has to be analyzed in future studies, but apparently the cohort studies indicate that, yes, they are effective in elderly patients. But Elisabeth, I don't know if you want to add something?
No, nothing to add. I think that we can continue with Frank and to see if there are other data to be sure.
Okay, thank you. So the question is, do the new data concerning single incision slings can change the current practice of functional urologists? These are my disclosures. So I do train some colleagues to implant a single incision sling, one of the types that has been investigated in the recent trial of Abdel Fattah. And I'm also a participant and scientific committee member of a European observational multi-center ALTIS study, which is sponsored by the producer. What are we doing here when we are treating women with stress urinary incontinence? I think it's important to understand that we are essentially most of the time treating healthy patients, healthy persons with a problem. So this means that we have to live up to the standards to treat healthy persons, and we are not treating sick cancer patients. So there are high levels of expectations, and this will come back later in the conclusions. We have to admit that there is a concern on the use of mesh materials, and there is a big difference between different countries. I think there are some countries, mainly Anglo-Saxon countries, where there is a high societal awareness of mesh issues and where patients are much more demanding on non-mesh solutions than in some other countries. For example, in Belgium, this does not have such a strong impact on our current practice. So there are some strong differences between different areas in Europe and in the world. And we also have to understand that even some of the non-mesh procedures have serious side effects, and they are often at least as bad than some of the mesh side effects that we can have. So the field is not black and white, and it remains something where we have to take into account several aspects. There is increasing scientific evidence around the entire subject, but still we have to admit that there are some uncertainties that remain present. And I think it's very important to be aware of these uncertainties and also to be able to name them. And we cannot have answers to all the questions that patients ask us. And so if we accept some of the uncertainties that still remain, like, for example, what Francisco just addressed, the dyspareunia, for example, then we have to take choices together with our patients. What do we know from literature? And these are figures that you can find numerous publications. These are some of the more relevant publications, in my opinion. You see that in different, more or less well-designed trials, same magnitude of exposure and erosion rates always reappear. So, for example, follow-up trial of a randomized controlled trial on transobturator and single and retropubic slings. The retropubic slings had about 4% erosion rates and the transobturator 2.3%, with a 88% follow-up of patients. And when the follow-up was prolonged up to 5 years, there were 1.7 new events. So new events did occur later than 2 years, although they were lower in numbers. In another trial, TVT had 2% exposure and erosion rates at 12 months and TOT 2.5. In meta-analysis, 1.8% exposure rate was found in the retropubic group versus 2.8% in the transobturator group. And in a Cochrane analysis, it was about 2%. And then in some of the retrospective series, the numbers seem to be a little bit lower in the Nielsen series, up to 17 years follow-up after TVT with a 2% asymptomatic extrusion rate. And then in Cocanali at 24 months, 4.2 and 3.5%. So you see, magnitude is similar, and there even seems to be inconsistencies into whether retropubic or transobturator slings do have higher erosion rates. So we're not really sure about the real numbers and the differences between the different routes, but we do see a magnitude of the problem. In a more larger study in the Lancet in 2017, from a large Scottish hospital discharge data set, an analysis was made in an interesting first single incontinence procedure population of more than 16,000 women. And in this large population, in 13,000 plus patients, so approximately 80% of the population, mesh was used to solve stress urinary incontinence. And you see the numbers. It was specified from a certain date on, and then they knew that more than 4,000 retropubic and more than almost 5,000 transobturator tapes had been placed. And these authors took open colpose suspension as a comparison, because this was still considered as the standard procedure, because this was the first procedure, as Elisabetta showed in one of her slides on the circular timeline, and because there is some data that open colpose suspension still outperforms laparoscopic colpose suspension as to the results of stress urinary incontinence surgery. And so they produce an interesting large table, and I'm going to stress some of the difference that they found in this observational trial. So if you take open cold pulse suspension as a reference, you see that retropubic mesh and transobturator mesh has lower rates of immediate postoperative complications. And if you look at the adjusted relative risk, it's significantly lower in these two groups, with even a little bit lower rate in the transobturator as compared to the retropubic mesh group. If you look at late postoperative complication admissions, you see that there is a little bit higher rate in the suprapubic non-mesh sling group, which is a relatively small group in comparison to the other groups. And the same is true for further incontinence surgery admissions. So these two elements deal with admissions. And then if you look at further prolapse surgery admissions as compared to open cold pulse suspension, again, the mesh groups, they do better, and they have significantly less readmissions for further prolapse surgery. So if you look at these large observational studies, the classical mesh do relatively well in comparison to the standard of open cold pulse suspension. Another JAMA paper, which was published in 2015, which is also the result of a very large population-based cohort study of approximately 60,000 patients with a mean follow-up of a little bit more than 4 years, showed that there was a mesh removal and revision in 2.2% of this large group. And they had a large database, so they could look to relevant associated risk factors. And it seems that surgeon volume is a relevant risk factor with a hazard ratio of 1.37. And this was not the case for specialties, so it doesn't matter whether you're a urologist or a gynecologist, but it does matter how many of these implants you perform. And other risk factors that were associated with revision rates were a patient with multiple mesh implants. So implanting multiple meshes increases significantly and with an important hazard ratio, the rate of repeat surgery and removal. Age is a protecting factor. So the older you are as a patient, the less risk you have for revisions, which makes a little bit of sense because probably they have less sexual activity and also maybe less follow-up. Concomitant hysterectomy is a risk factor, and also being operated in an academic or teaching hospital is a risk factor. So you see there are some elements that we know from literature that can impact the incidence of problems. In this large database, they also saw that in latter years, there was an increasing rate of intervention, and the authors claimed that this might be caused by an increased attention to the problem and that the erosions were better detected and treated. What they also saw is a repeat of what I mentioned in one of the previous slides, that even on the long run, there are some additional problems that occur. And so extrusion, erosion do occur, and exposure even after more years. And although the numbers or the additional numbers decrease over the years, also the number of patients at risk decrease, but still at 7, 8, 9, and 10 years, a small number of additional problems do occur after implant. So it's important to realize that these problems exist and that they remain existing on the long run as well. If we look at efficacy of sling procedures, this is a meta-analysis of Fusco published in European Urology, and it showed that the mid-urethral tapes do as well, because it's not statistically significant better, but there is a trend to going a little bit to the favor of tapes versus open birch cold pulse suspension, and they do better than laparoscopic birch cold pulse suspension on overall cure rate. And so the author stated that there is a superiority of mid-urethral sling over birch cold pulse suspension on the treatment of primary female stress urinary incontinence, and that it's significantly more effective tapes versus birch. And if you look at overall cure rate of autologous versus synthetic slings, there was no important difference. And in this meta-analysis, the authors concluded that they were equivalent, the mid-urethral slings, synthetic mid-urethral slings, equivalent to pubovaginal slings, but that there was a statistically significant lower instance of storage sluts when patients were implanted with synthetic mid-urethral slings, and this was shown in another graph. On the longer follow-up of the randomized controlled TOMOS trial at 5 years, with 404 patients having attained 5-year follow-up, they showed that retropubic slings were superior for the specific cure of stress urinary incontinence, and there a 51% cure rate was attained versus 43 for TOT, but the satisfaction rate was a little bit different, with an 80% satisfaction rate for retropubic sling and an 85% for TOT. And the explanation in this study was that in the retropubic group there was more urgency and more sexual dysfunction, and by consequence less quality of life. So it also shows that not only the specific cure for stress urinary incontinence is important, but also the more holistic approach on urgency, sexual function, etc. And that in both groups, both retropubic and TOT, quality of life, sexual function, and patient global impression of improvement, they did decline a little bit over time, but they remained significantly better versus baseline. So the vast majority of patients do fare very well after these surgeries. So what is the conclusion of such a trial? That the efficacy of even polypropylene slings do not last forever, and that even in the time frame of 2 to 5 years, there was still a small percentage of new exposure, and that this is a small number, but still it does exist, and that in the majority of patients, the high satisfaction rates do remain at 5 years. What about the recently published New England Journal of Medicine paper of Abdel Fattah? This is a very important paper because it's a large, well-designed trial that's non-industry driven, and it has been run in multiple centers. They have compared the adjustable single incision mini slings, and they showed that they were non-inferior to the standard mid-urethral slings, and these standard mid-urethral slings, or this group, composed both the TOT inside out, outside in, and the retropubic slings, and this was true at 15 and 36 months. And so this is actually a high level evidence confirmation of what we have already seen in other smaller RCTs, and it has been confirmed with robust methodology. And then one of the questions that still remains is what Francisco already alluded to, that there was possibly a slightly higher erosion rate in the single incision slings, and also a very high dyspareunia rate in this group, which needs further elucidation, I think. So what does this all mean for current practice? I think it has already been clarified a little bit in the first elements we saw in the 2023 European guidelines. I think stress urinary incontinence surgery should not be treated like a Cinderella. I think if you want to do this treatment, you have to be committed. You have to train yourself. You have to know the specific type of surgery that you want to perform, be it single incision sling, be it retropubic, be it transobturator, or be it one of the native tissue repairs. I think you have to try to perform adequate volumes of surgery. Don't treat single patients, one in a month, but try to really dedicate yourself to this treatment and try to attain large numbers. And if you do not have large numbers, refer to a colleague or in your own hospital or in a hospital, so that the surgery is a little bit concentrated and you have high quality of surgery. Secondly, be careful. Don't be a cowboy. Don't go implanting multiple slings, certainly not without decent informed consent of your patients. You know that your first shot is the best one, so that's why the first element of being committed is so important. be careful when you want to perform concomitant surgery. It has been proven that, for example, an associated hysterectomy is a risk factor for problems afterwards, although it was not very strong. It is a risk factor. And even age was an issue, and we have the unclear figures on dyspareunia. So be careful in implanting tapes in young patients, and at least have a decent counseling of your patient. This brings me to the next topic. Be honest to your patients. So inform the patient with the best available data from literature and preferably even from your own experience. If you have large numbers, try to know your own complication and reoperation rates, and also be honest in a way that you can offer alternatives. I think if you have alternatives within your center, within your department, that's the best you can have. But if necessary, if patients are, for example, looking for non-mesh alternatives, you have to be able to refer the patient to a colleague who can deliver this. And so you have to know the field that you're operating in within your area. I think personally that sling remain at least an available treatment for the primary treatment of stress urinary incontinence in women, and in my opinion, even the best available treatment. We have to realize that every single treatment has its fingerprint, meaning that it has downsides and upsides, and I think that's why we have to do a complete and honest counseling of our patients. And so again, we still have some uncertainties in this field, so there is no perfect data. And one of the elements is the long-term effect of all the treatments. And so this is why the shared decision-making and the patient involvement that Elisabeth already mentioned in the new guidelines is an essential element in this type of surgery. And this was my last message to all of you.
Thank you, Frank. Thank you very much for your very clear presentation. Let's wait a little bit for Elisabeth. I think one important point you mentioned while Elisabeth she's coming, is that no, these surgeries do not last forever. I think this is an important point, particularly when we treat young patients, because there is an idea that, the results at 12 months, at 36 months are so good that they will last forever. But if we go to the Thomas trial at 5 years, clearly the results are not so good. So something that we have informed very well our patients. Elisabeth.
Well, I think that we can reply to Christopher Harding, who was asking about an important question. And he asked us, do you think that removal of mesh is a good metric for complication rate? The number of surgeons who can perform mesh removal is relatively low compared to surgeons that can insert it. So could the difficulties in access to removal service underestimation or complication? I think so that it's a very difficult reply because we don't know if the complications are underestimated, but I would like to know your idea and your opinion.
I would also argue the opposite, that I have the impression that in some areas, mesh removal can be a goal in itself. And I had some discussions on specific patient cases where I would not go for mesh removal and where some of my colleagues would go for mesh removal. So I agree that this is a very difficult and sometimes subjective area. But I do agree with Chris. I cannot read his chat, but I do agree that access to mesh removal might also be a problem. I think it goes both ways.
Yeah, I would say that this, if we, particularly in Anglo-Saxonic countries, if we all go back to the synthetic slings, some centers will need to have experience on mesh removal, because the number of cases will be very, very low. In some cases, it might be very difficult. And to have one surgeon that has the experience of one case last year and another surgeon, one case last month, that is nothing. And the results might not be as good as they could be if those cases are concentrated in a single center. But it is a difficult issue because we don't have good information about that. Definitely.
Yes, I agree with you that we don't know if the complications are underestimated. And I agree with Frank that in some cases we don't need to remove the mesh. And there are some cases which are completely asymptomatic. Probably these cases are underestimated. But it's true that there are some complications which are terrible. So we have on the plate a lot of complications which are not so important. So if we think that a lot of complications during the retropubic route is only the passage into the bladder, which is nothing, because there is not a problem, which is one of the complications. And at the same time, we have some cases in which we have a really big complication. So I think that these cases are not underestimated, because these are the cases which reach the principal centers, and so the real are not underestimated. That are really. And what is important is that we don't know the real number of midi-retro slings performed worldwide.
Yeah.
Because probably, so now all the data are only part of a really big world in which we have a lot of procedure performed in not trained centers, and probably the majority of these complications are related to the surgeon. I think that this is the truth.
But Frank, you would probably agree that the main reason to remove or to make a reintervention is an obstruction. And in most cases, we don't need to remove the entire sling. We just need to cut the sling, right?
I agree. I think if you perform a clinical examination and if the sling is well positioned, if it's flat but obstructive, I would cut it. If, on the other hand, I would feel the sling is tense and not flat but rolled, wrinkled or something, then I would remove probably part of the sling. So it depends a little bit on the case.
Yeah, but you don't go immediately for the removal of the entire sling, the midi-retro sling.
I would personally not do this. I think I want to analyze what is the problem, and I will do the minimal surgery to solve the problem.
Well, there is another question that we can reply. The question is there any discrimination regarding the severity of stress urinary incontinence in the published data with mini-slings? Frank or Francisco?
No, it's randomized data, so no. Easy.
From randomized data, no. We had experience from our own cohort, but that is a single center cohort. Patients with more severe forms of incontinence did worse with than the patients that had less severe forms of incontinence. So if we can extrapolate that, saying that patients that have 5 or 6 pads per day need to have a midi-retro sling, there is no randomized clinical trial, so we have to be careful to extrapolate those data, because probably those patients will also do worse doing midi-retro sling.
And there might be some data, but it's observational, small cohort studies on retropubic or even adjustable slings that would do better in severe incontinent patients with the price of some dysuria. But I think the answer to the question is that we have randomized data, and in these data, there is no difference.
Right.
Well, Chris replied to Francisco, and he says that a great point to centralize the removal services. I completely agree with him. and it should be done when possible. And then we have another question, if we have time.
Yes, we have time.
So concerning quality of life in a woman who developed urine retention with the need of self-catheterization 2 times a day after a midi-ureteral sling implant, would you suggest to deal with the necessity of IC and preserving continence, or going for mesh removal? It's a good question.
That's a good question. Well, that makes me remember one of the very early studies with Botox in patients with multiple sclerosis, and patients were extremely happy because they were continent. And not because, and there was no big difference between doing CIC or not doing CIC. They were happy because they were continent. So I think this case needs to be very well discussed with the patient, because if the patient had a very severe form of incontinence, and if she is now dry and she is able to do the CIC very easily 2 times or 3 times a day, I would probably try to tell her, keep the situation as it is because you are dry. The other thing is, a patient that has a very mild form of incontinence, now we have an obvious complication. I would say, well, let's cut the sling, because it's not practical for a woman 50 years old to start doing CIC for the rest of her life just because the sling is too tight. I don't know your opinion, Frank.
I completely agree. Thanks, Giovanni, for the nice question. I completely agree with you, Francisco. Just you address this with your patient, and in the end, the choice would be in the hands of the patients. But if I would do anything, I would do probably a unilateral sling transection in order to keep the patient as continent as possible.
Yes, I completely agree. And the other important point is the time when the sling was positioned, because it's another important point. Because after a long time, your results of a mesh removal is not so good, and so you have to inform very well the patient. Then we have another question. There is another one. Is it preferred to implant a retropubic sling when the patient is overweight? What do you think?
For me, I don't have evidence that overweight patients will do better with the retropubic slings. The retropubic slings are slightly more effective in the long run, but we don't have the evidence that being obese, they will do better with the retropubic slings.
Same opinion, and yeah, we do know. I think we do know, not perfectly from high-level data, but we do know that probably retropubic root is a little bit more performant on treating the specific issue of stress urinary incontinence, but at the price of a little bit more voiding dysfunction.
Yeah.
But not well, I don't agree with you in this case. So, in the sense that I think that the retropubic tape is a wonderful midi-ureteral sling, and if you position in the right way, you have a long-term outcome, which is confirmed in a lot of study. And I generally prefer to perform a retropubic very obese patient. Mm-hmm. So you know that the data are not available, and we have none. But in my personal experience, analyzing my data, so it's only my opinion, not like guidelines member, okay, is that in this case I prefer a retropubic tape, but I don't put tension. So I perform procedure as in a normal weight patient, mm-hmm. But I think so that sometimes it works well, but it's only my idea.
On the other hand, I'm going to challenge you. Putting a single incision sling in an obese patient is easy, while when you need to move the needles through the obese patient, it might be more difficult as well.
Yeah, for sure. So we have another question that probably we can reply by Fernando, I think. So what is the Europe and the EU stance on a midi-ureteral sling? pretty much abandoned in the UK.
So Elisabetta, what do the guidelines say?
Oh yeah, I show the guidelines. So the guidelines show that we have to be open to any kind of solution, and if you have a good counseling with your patient, but exactly where the guidelines indicate exactly what are all the different steps to obtain a counseling on this procedure, and you can perform a colpous suspension, a rheumatologous sling, or a mid-urethral sling. So it depends on the discussion of risk and benefits for each of these procedures. So we are not, Europe is not against the mid-urethral sling, is in favor of a very well discussion with the patient.
Yeah, although I think that the problem is always experience, and I think with the artificial or synthetic slings, the problem a few years ago was that it was considered a very simple and easy surgery, and many surgeons start doing it, choosing the wrong patients and doing it in the wrong way. So I think if the surgeons are appropriately trained, the results will be good and certainly much easier than the Bursch-Kopple suspension. I don't think, to be realistic, that we can go back to the Bursch-Kopple suspension, laparoscopic or open, because it is a longer operation, much more complications. The time in the OR is much longer. So I think we have to go back to the synthetic slings, but we have to train well our surgeons, and that is, I think, an important message.
I agree, and also on indication, I think the worst cases I've seen on disasters after sling implant was when a patient with very limited stress urinary incontinence problems was actually convinced by the surgeon to have a sling performed because it's a very simple surgery anyway. And if then you have any complications, this is a nightmare scenario. So I think it's not because the treatment can be very efficient and can be very small that you should go really light on the indications as a doctor. That's also a very important message.
Yeah, it's very easy to improve a patient that leaks a lot, but it will always be a very complicated to improve a patient that leaks occasionally. So one has to be very careful when selecting the patients, and that is also part of the education. It's not only the technical aspect, but the selection of the patients. Well, just to finish, because we are running out of time. Frank, what would be the surgery you would select for my Portuguese patient?
Your Portuguese patient was a 55-year-old active patient with primary stress urinary incontinence who was had pelvic floor treatment. So personally, I would go for a single incision Altis sling on this patient. That's my personal standard of care.
With a lot of discussion about dyspareunia.
I still,
because personally you don't have.
I don't think 70. I think 70% is relatively high, but I always discuss specifically the fact that I will implant a non-resorbable material that it will stay in my patient for the rest of her life, and that it is prone to specific complications of the mesh on itself, including dyspareunia.
And you, Elisabetta?
Well, no, in this patient, I can perform both without any problem with a transobturator table or a single incision sling. Recently, I use a lot of cases with single incision sling, and I think that it's a very nice procedure. But some timing depends on what I have available in my operating room. I have to be honest. Okay, it's really a good procedure. And regarding the sexual problems, it's clearly due to incorrect positioning of the mesh, because it's not so easy. I think so that it is easier a transfer to tape sling, single incision sling. So when you perform this kind of procedure, you have to be trained. In this case, you will have not any kind of sexual problems. Yeah, completely agree. And I have seen that there are a lot of questions. I think so that we can reply later.
Yes, later.
To the other one, and I think so that it's. I thank you, Francisco, because I think
we have to finish.
Yeah.
We have to finish. Thank you, Elisabetta. Thank you, Frank. Thank you to the office by the technical support and all the audience that remained with us during this last hour. Thank you very much for the collaboration. And well, we'll see probably in Milan, hopefully in EU meeting. Thank you and spend a good evening. Bye.
Bye.
Thank you.